just to start out, a little bit about us. Tillsonburg, as everyone knows, has got a large aging population. In fact, it's higher than the average for Ontario, and especially with the 65 to 84 age groups, we have always tried to, as a community, encourage Tillsonburg as a retirement community and have two developed communities for people who want to retire. That does pose a challenge for our community in the fact, at least for our hospital and the services we provide for healthcare, in that those individuals who come to us and are living in our community are away from their families. They have no support. Oftentimes they're coming from Toronto or outlying areas where they don't have that family support. So having programs such as this transition team and the aging outcome strategy, we've been able to help support that need that is there. And for the hospital, as everyone knows, there's budgetary constraints, and we had to find some money. We had to find some savings and do some better cuts. So that was what our biggest concern was for us, from our perspective, as well as our patients. So the challenges with those budgetary constraints bring an opportunity for us, and that was partnering. Partnering with our organizations such as CCAC. We always had a really good working relationship within the hospital, really great rapport and communication. Multi-Service Center and Maple Manor Nursing Home as well, but the Multi-Service Center has really got some great programs. So when we got together with Tom's leadership and Sandra Coleman, helping us out, getting us started and building that approach to the team was really beneficial for us. And then the purpose was, as you know, to assist seniors to remain in their homes. People don't want to be in hospital. Generally speaking, they want to go back home. They don't want to go to a long-term care facility. They want to be able to be supported in their home. So these programs that we have are providing that ability for people to be at home. We had to decrease the pressure for eMERGE with all of the backlog that we experience, as other local hospitals do as well, occupying the inpatient beds for a lot of those ALC patients. So we needed to look at that. And we also had to look at reducing some complex continuing care beds. We recognized that if we had those programs in the community to support people to be at home, then we could in turn reduce those complex continuing care beds. So we have had an oversight group that monitored and championed the processes through that transition team. Our Flow Collaborative, which has really been instrumental as well in helping to coordinate with this transition group in having our daily bullet rounds. That's been really instrumental with the Flow. That's probably one of our key successes, having those daily discussions about our patients, what's the barrier to discharge, and having physician involvement, having all of the interdisciplinary teams. So that's really been beneficial in conjunction with the transition team. Education for the community. Vicki, as transition case manager, has provided education to various community groups, including the Senior Center, Hickory Hills.
We also held a community health fair in October last year, and it presented as a forum for our new programs, but also we invited different retirement homes, the nursing homes, different services in our community, and we invited the seniors to attend. And we also have been trying to, we had a booth at the Home and Rec show with the Multi-Service Center as well. So we're trying to get the word out there and educate the community about what resources and supports are out there associated with our transition team. And also I've done education with physicians, our service providers with CCAC, the Southwest CCAC as well. Oh, thank you. Sorry. We also, Community Care Access Center, last year, we also expanded services in the home, which partnered with our transition team and helped with our initiative to get people out of the hospital and supported and staying in their own home. We had a Safe at Home program, which involved nurse practitioners. So it was a hospital avoidance to get the nurse practitioners involved with more medically fragile clients to keep them at home, avoid the hospitalization if they could, if that was at all possible. So they would work together with the family physicians and the case managers if they were involved with a particular client. We had the wait-at-home client, and that was to avoid hospitalization for waiting for long-term care. So it was increased, unfortunately it's on hold at this point, but it was to increase services at home while a person waited at home rather than in hospital for their long-term care. And we also had new service maximums last year. They helped to increase the patient flow through the system. The program components, the transition team, we have CCAC case management in hospital and in the ER. We are part of the discharge planning in the hospital, and we try and help facilitate patient flow throughout the system. Basically, the case manager is the lead on the initiative, and we also provide education in the ER and to the physicians that come into ER as well as in hospital. We have the expansion of our current assisted living and community program. This was a program by the multi-service center, and it was expanded by 11 slots initially, just simply for Tillsonburg Hospital. So basically, it was supportive housing. If you've heard of supportive housing buildings, and they provide the support in the building. Well, this was taking it out of the buildings and providing it in the client's home instead. So they get to stay home with that kind of support, which was excellent. I think we're now up to 12. For hospital only. Okay. And there is one.
For hospital, there was 12 spots, but we have added an additional spot.
And we also had social work involved with Tillsonburg Hospital patients. Before, social work wasn't in the hospital, so it was a creative idea that the social work with the CCAC would come in and see clients in the hospital to facilitate a transition back home if there were any family dynamics or any issues that needed to be resolved. And what was nice about that is that we were consistent. The social worker that saw them in the hospital was able to continue to see the person at home when they returned home. And also we had the social worker see clients who had difficulty with that transition to long-term care as well. That's a big change in somebody's life and a lot of losses, so that was also very helpful. And to date we've had 14 referrals to that program. And we also have the interim long-term care beds. We have a total of 5. Basically, what they're used for Tillsonburg Hospital only. Patients can wait in these beds that are in Maple Manor as well as one at Corrective Care Portland instead of waiting in hospital for their long-term care bed. Because basically what we've had is a lot of our chronic care clients are just waiting for long-term care in hospital. So instead we were able to have 5 clients move to Maple Manor and Crescent Care to wait instead.
It's been a really beneficial piece to this whole puzzle to have those beds available to us. And they've turned, 14 times?
14
in just a year. So that's really been helpful.
It's relieved a lot of
It has.
Yeah. And when we were doing the beds, it really did help out.
Another piece I just want to mention too with the eMERGE visibility, where CCAC has been extremely helpful, has also been with intervening before the patient's actually admitted. So seeing that patient, assessing them, what more can we do for them in their home? Is this a medical reason why they're here, or is it a social reason? And can we get them back home and give them the support they need in their home? And that really has helped, because we've noticed that there's been a few that could have ended up in our beds and ended up going back home. So
that's going home or to a supportive environment in the meantime until they got strong enough to return back home. The transition case manager role, basically we added just a case management position to help facilitate the flow of ALC or more complicated clients that were finding themselves in hospital and not able to return home, or clients at risk. So we would identify them, like Kelly said, in the ER. My role also, like we said previously, was to educate and provide information, care connection, let the community know of what resources and supports that are there, like the LCOM program, Home at Last program, and any other community support services. And in the hospital, we would develop a plan and really involve the family, the client, and the Tillsonburg Hospital team physician for the most appropriate discharge destination, and to create a plan that's fitting